Hello, and welcome to episode 1 of Spinalcast. I'm your host, David Stevens, and joining me today as co-host is Rich Sluice. Rich, along with being a wonderful individual, is also a board member for the Morton Cure Paralysis Fund. During today's episode, Rich and I will be interviewing Dr. Ann Parr of the University of Minnesota, in which she is a dedicated spinal cord injury research scientist. This is going to be a pretty interesting conversation, so let's go ahead and jump into it. Hello, and welcome to the first episode of Spinalcast. Joining us today is Dr. Ann Parr from the University of Minnesota. We're very excited to have you, so thank you for joining us.
Thank you for having me.
And we're going to go ahead and ask you some questions about the research you've been doing and kind of what you've seen in the world and what's going on in the SCI community. So I figure if you're comfortable with it, we might as well just go ahead and get into it.
Yeah, let's do it.
All right.
Let's do it.
Perfect. So I guess my first main question for you is how did you ever wind up researching spinal cord injury, or how did you become affiliated with spinal cord injury in all of your studies and things of that nature?
Well, there's really a couple of reasons that I became interested in spinal cord injury. I think the primary reason is probably the patients. When I was a medical student and when I was subsequently a resident in neurosurgery, I actually didn't go into neurosurgery with the idea that I was going to research spinal cord injury. But I have one patient in particular that I recall when I was a first year resident, a young man who had worked on a farm out west, and he fell off the one of the pieces of machinery and unfortunately sustained a spinal cord injury. And I knew at that moment that he wasn't going to be able to inherit his family farm and to take up the family business like he had, the family had hoped for him, and all those hopes and expectations for him, I think, had just changed in that instant. And that's one of the things that kind of stuck with me over the years. And there were many other patients similar to that. So that was the primary reason, I think. It just seemed really unfair and really unexpected. And then subsequently, I also became interested in spinal cord injury because of the science behind it. I think that neuroscience is, of course, I think it's the most fascinating thing in the world.
We don't understand it. We appreciate that.
And it's so interesting. And it just seems like it always has seemed to me that there is a treatment out there. There is something more that we can do. We just don't know what it is yet. And so that sort of led me down that path.
So the main problem kind of posed by spinal cord injury, I think, is difficult for certain people to understand. In your understanding of it, how would you present the problem that spinal cord injuries pose to those injured?
So that's a great question, because I think that amongst the average population, there is a poor understanding of what spinal cord injury actually means.
Yeah.
And so many people think that spinal cord injury means you can't walk and you're in a wheelchair. But that's really only part of the problem, and a very small part of the problem. For people that are injured in the thoracic region, they can't walk. People that are injured in the cervical region often can't move their hands or have limited use of their hands. And the higher you go, you actually lose more and more function. And many spinal cord injured patients with high cervical injuries can't breathe on their own, so they need permanent ventilation. Patients with spinal cord injury also lose sensation below the level of injury to differing degrees. They lose sexual function, they lose bowel and bladder function. And often they have dysregulation of which a lot of people don't know about this problem. They have a dysregulation of their blood pressure, and that can be life-threatening. And so all of these things are, significant components of spinal cord injury.
Getting back to your research, what was the first big project that you took on when you began your spinal cord research journey? What was the first project that you really kind of got started with?
So the first big project that I got started with was back when I was doing my PhD in Toronto. That's when I really started doing spinal cord injury research. And the lab I was in decided to investigate stem cells for spinal cord injury. And stem cells were sort of in their infancy back then. I was in the early 2000s. And if I knew then what I know now, I'd be a lot farther ahead,
Right.
But I think that I've really watched the field progress over the last couple of decades, which is kind of incredible. But yeah, it was a stem cell project. It was transplanting neural stem cells in a rat model of spinal cord injury. But the stem cells really were not, one of the biggest differences is that they weren't very well defined, because it was only in the 90s that we realized that stem cells actually are present in adult human brain. And it was always thought that they were just present in embryos and fetuses. And then after we became adults, too bad we don't make any more neurons in our brains. Turns out that's not true. And it's lucky for all of us. But there's a few areas in the human brain. And then in the 90s, it was discovered how to grow the cells in a dish. And so that was sort of what brought about the beginning of research into stem cell transplantation for spinal cord injury.
And do you think that's exponentially growing in terms of our knowledge and
absolutely? Like, some of the things that we've learned are that all neural stem cells aren't the same. Back then, it was sort of thought that, it's a cell, you can take it from a human brain in a biopsy, for example, and you can grow an addition. It's going to be like the same, but that's not true. I mean, and I guess now that it seems kind of obvious, but I think back then we sort of thought that all the stem cells were the same. But it turns out that if you transplant a brain stem cell into the spinal cord or vice versa, they don't really like the environment. They don't grow as well. They don't really do the same things that we want them to do. So it turns out that regional specificity is really important in stem cell research. The other thing that's come about is iPS cells, and that is induced pluripotent stem cells.
Pluripotent.
We'll test that.
They're very potent.
Yeah. Yeah. So we should hope so. But it's really an exciting area of research, and it's something that we do in our lab. And basically what it is that one of the major problems with any kind of transplantation research has been patient matching. You know how if you want a bone marrow donor, you have to go out there and find someone who's genetically similar. If you have a twin, that's lucky. If you have a close relative, that's lucky. But if you don't, you're kind of out of luck, And then for things like kidney transplants or heart transplants, you're on immunosuppressive agents for the rest of your life.
Right.
And so a few years ago, this Japanese physician, researcher, I shouldn't say physician, he's a researcher, Yamanaka, he actually won the Nobel Prize in Medicine for this. And he discovered or invented the iPS cell. And basically, one of the things that is known is that you could take one of your cells, your skin cells or your blood cell, and you could turn back the clock to make it into like an embryonic stem cell.
Wow.
So basically turn it back to your own cell when you were an embryo. And then you can subsequently culture that cell to make any cell type of the entire body. So in theory, I could take your skin and make it into a kidney if you needed a kidney, or I can make it into a heart if you needed a heart. So this has only been discovered. The technology for this was only discovered a few years ago.
Wow.
So it hasn't obviously gotten to the point yet that we can make new hearts and new kidneys and things like that, but it's getting there.
Yeah, the science is pointing that way.
Yeah,
and
absolutely.
How far away is something like that?
Maybe 10 years. Yeah. So the first thing that researchers have gone after is actually AMD, which is it's an eye disease because they can grow new retinas with this technology. And so it's been applied to that area first. And next, they're going to apply it to spinal cord injury. So there actually is a clinical trial that just started. They've enrolled one patient so far, and it's in Japan. Because Japan has, in the United States so far, there are quite a few regulations, and there's a reason for regulations, but it's quite restrictive using iPS cells. They have to go through a lot of hurdles. Japan has kind of taken a different approach to it, and they've made it so that there's special exceptions. And so they've accepted their iPS cell banks to allow for these clinical trials to move ahead.
Well, so having been involved with the Morton Cure Paralysis Fund my entire life, I've always heard stem cell research kind of talked about as like, this is the path forward. This is the path forward. And talking to you, it sounds like stem cell research is still a very heavy part of the research being done. But then hearing things about iPS cells and things like that, is stem cell research still as heavily involved in all of spinal cord research as it is? Or are new things coming up and people are like, well, maybe stem cells aren't the solution for spinal cord injuries. We're finding all these other great things that they do. But maybe we should start targeting these new avenues outside of stem cell research. Or am I misunderstanding stem cell research as a term?
No, I think I'm really glad that you asked that, because I would really like to be able to emphasize that there is unfortunately, there's not going to be one magic bullet or one cure for spinal cord injury. That's not going to happen. And I think that most researchers recognize that. Every spinal cord injury, first of all, isn't the same, right? There's cervical versus thoracic. There's complete versus discomplete or incomplete injuries. And there are different mechanisms too. And I think that what's clear to most people is that one size does not fit all, and that, this era of patient specificity and tailoring the treatment to the patient rather than have something for everybody. So it's more like a toolbox, a kit.
Yeah.
So I think that there are going to be combinatorial therapies as well that are going to work, that are a combination of different things. So I think that nobody should put their eggs in one basket. I think that, and so all of the things I've talked about so far today have been, I would say, in the realm of stem cell research. And I think that's still a huge thing. But I also think that when you're talking about research into anything, you need to make short-term and long-term investment. And if you see something that might help a little bit today, that's something worthwhile. But if you see something that's more of an investment that might help 10 or 20 years down the road, then you should also consider investing in that type of research so that you really don't have all your eggs in one basket. And so I think that the stem cell research, while it's moving forward, definitely, it moves forward at a slow pace. And there's a lot of things about this clinical trial that is going on in Japan that I'm sure are not going to be perfect. Hopefully they'll get positive results. But I think there are going to be some snags along the way and things that they need to tweak about the research. But it's a start, right?
Right.
On the other hand, the other thing, that I'd like to bring up is epidural stimulation, because that's another avenue of research that I'm undertaking and others are undertaking. And I think that's the short-term thing, the thing that can help patients today.
Yeah.
However, I have to be a little bit careful, though, because I think some people are interpreting all of these amazing findings with epidural stimulation as being the answer, but it's not. It's not perfect. There are a lot of things that epidural stimulation does, but there's also a lot of things that epidural stimulation does not do.
Can you tell us a little bit about what that is?
Absolutely. So epidural stimulation is basically, it's a surgical procedure where you have an electrical device implanted into your body. There is a paddle that goes over your spinal cord, but over the lining that surrounds your spinal cord. There's a wire that comes, and there's a battery pack that goes under your skin. But it's a pretty good treatment. So, and it's easy as a surgeon, it's easy to put in. Low complication rate.
Go gadget, no more pain.
Yeah, exactly.
Yeah.
So it was discovered about 10 years ago, a little bit more, serendipitously, that this can actually restore volitional movement after spinal cord injury. So it turns out that, and it's not fully understand how it works, but there's some pretty good theories, and we sort of know how it works. And basically, most people with spinal cord injury, it's actually very rare to have a true transection, which means like cutting the spinal cord. So
Right.
even in patients that have no motor or sensory function, 0 below the level of injury, it's rarely a transection. It's usually a crush. So what that means, though, is that there are still these nerves that cross the area of injury. The problem is there's not enough of them to generate any kind of significant response. But what if you could somehow make them more powerful?
Right.
Those few nerves that are remaining. So the thinking is that when you put in this epidural stimulator, you basically provide a very low level of stimulation so that the nerves down there need less stimulation to be active. And you can kind of think about it where, let's say, that light bulb over there, let's say I have a switch over here. Okay. And it turns the light bulb on and off. Let's say that the wires going to the light bulb, I cut half of them. So now there's not quite enough power to turn the light. So I flick the switch and there's nothing, right? But let's say that you hook up a battery to that light so that you provide sort of a low level of electricity, but not enough to turn the light on. But all of a sudden the switch works again. So that's kind of how you can think about
booster.
Exactly.
Yeah.
Exactly. It's a little more complicated than that. I'm kind of simplifying it a little bit.
It helps me. I wouldn't have had any understanding without that kind of explanation. So
we have some clinical trials ongoing here in Minneapolis. We're one of the only centers actually that has clinical trials ongoing. So we're really excited about that. And we've had some really good results.
Awesome.
Actually every single patient we've enrolled. And I think there's about 18 or so enrolled so far. But every single patient we've enrolled has had benefit. They've been able to. And these are patients that some of them haven't moved anything below the waist or for a decade. And now they can have some movement.
Yeah.
It's amazing.
It is really amazing to see. But I will caution you, though, that it's not perfect, right? Because you're not regrowing the spinal cord. We have had some cases, very exciting, where even after a while, even after you turn off the stimulator, there's still some volitional movement there, which means there has to be some neuroplasticity where the nerves are reorganizing themselves, which is really exciting. Yeah.
How often do you have to change the battery?
It depends how often you use it. It's a great question.
Oh, okay.
Some of the newer stimulators have rechargeable batteries. But yeah, it could be every few years, could be longer or shorter, depending on how often it's used.
As far as using it then, so they select when it's on and off.
Mm-hmm.
Interesting.
Yeah. And they also select. So one of the big things that isn't known is exactly how to optimize the stimulators. So this is one of the big areas of research right now, is actually how to, because the stimulators, they have different electrodes on them, and you can turn them on and off. And you can also change the frequency, because it's a stimulation pattern. It's like a wave. So you can change the amplitude, the frequency, the pulse width. So it's pretty much an infinite number. It's not quite infinite, but it's close. There's 3 trillion or something like this,
An
different settings.
Number.
Yes. So we have to figure out better ways of optimizing these. But as I said, though, it's not a cure, because these patients are not recovering sensation. They're recovering motor function, which is not a small thing. They're improving their bowel and bladder function. And we don't know yet whether that's because we're actually improving the bowel or bladder, or because they're more able to, for example, their truncal stability and things like that are better. Their bowel evacuation times are reduced significantly in these patients. Quality of life is improved. The transfers are easier. They're reducing their spasticity. All these different things that the stimulator's helping. So it's definitely 100%. This is like the thing right now, really, to be excited about. That I think many more patients could benefit from this technology. It's and I've seen, like, even over the last few years, like, the number of patients that are getting implanted is going up exponentially, and I think it's going to continue to go up exponentially.
Well, so that leads me to an interesting question. So going back to something you mentioned earlier, is that there's kind of their research for immediate solution that give an immediate benefit, and then there's that long-term research. And this sounds a little bit more like that immediate benefit. It's not the It's not going to solve anybody's ability to not be able to walk or anything like that. But
well, there are patients though that are walking now.
Wow.
Oh, wow.
Yeah. Yep. It's not
huge.
everybody, but and some patients, they need like a standing device.
Right.
But there are patients that are walking again after this.
That's awesome. Wow. As you can tell, we had quite the conversation with Dr. Ann Parr. So much so that we actually decided to split it into 2 episodes. Part 2 will drop 1 month from today, so keep your eyes peeled for that. And actually, if you're watching us on YouTube, right now might not be a bad time to hit that subscribe and bell icon so you know when new episodes drop. If you're listening to us on your favorite podcast platform, you could always throw us a follow. We wanted to thank Dr. Parr again for being our first guest on Spinalcast. It was an absolute blast to have her on set. And thanks to Rich for being my co-host. All right, well, hold tight, and we'll see you at part 2.